Hello, and welcome to the setup presentation for your Well Child Exam Lab.
What will you be doing this week in lab? You're going to be performing your first well child exam on a real pediatric patient. One of the things that I've observed when I precept third and fourth year students is they tend to be pretty good when a patient comes in with a specific complaint. But when a patient comes in just for their well child exam or otherwise for some sort of a screening exam, like a sports physical, they're unsure of what they should be doing. So, this lab is going to give you some experience with that even before you start your clinical rotations. You will be expected to gain experience gathering a history and performing a physical examination on a pediatric patient. You'll plot patients on growth charts and then turn those growth charts in. You'll also write prescriptions and turn them in for amoxicillin. In pediatrics, we do prescriptions a little bit differently, right? So when we're calculating out how much amoxicillin to give, it's based on the child's age, their weight, and their diagnosis. So you'll get some experience doing that as well. You're also going to practice your patient presentation skills. And of course, have a lot of fun playing with the pediatric patients.
Well Child Care is a very important aspect of outpatient pediatrics. It involves primarily anticipatory guidance and preventative medicine. It is a fantastic adjunct to osteopathic education. During the Well Child checks is when the children are receiving their immunizations, when we are screening them for hearing and vision, when we are screening them for any developmental delay, we're screening them for home safety, personal safety, we're monitoring their growth and development, we're screening their vital signs and labs for any abnormalities. As I've mentioned, the Well Child check often leaves the third year and sometimes even the fourth year medical students stumped. They go into the room and then they wonder, what should I ask? What am I supposed to focus on? Do I do a full examination or just a partial examination? When I'm writing my note, what exactly is the assessment and what's our plan? How often do we do Well Child checks? We do them within the first couple days of life. So newborn check at 2 to 5 days old, making sure they haven't lost too much of their birth weight, checking to see how breastfeeding is going or if they're formula feeding, how that is going. Then we're going to do Well Child checks routinely at 2 months, 4 months, 6 months, 9 months, 1 year, and then continuing to march out, 15 months, 18 months, and finally at 2 years and then annually every year after that until the child is no longer a child, until adult age of 18 years of age, or until they've transitioned over to a provider of adult medicine. The very first thing that you should ask as you enter the room is ask the parents if they have any questions or concerns. So checking in to see if anything else is going on at this preventative care visit. And then you're going to ask how the child is doing. You're going to do a little bit of a review of systems. Have they been sick at all recently? Have they had any fever or cold symptoms? Have they had any constipation or diarrhea? Is the child in school? And if so, what grade are they in? How are they doing in school? Do they need any extra help? And this is a great time to educate the parents on their right to obtain an individualized education plan. So at all public schools, every child has the right to have an individualized education plan, which is developed by special education teachers, as well as principals, as well as social workers. They all get together and assess a child and determine what special services that they need. You'll notice as we go through this, most of your screening questions are ideal lead-ins to delivering anticipatory guidance. So the whole time you're asking questions, you're also counseling and educating the patient and their families. This is how you're able to do a full Well Child check in that 15-minute time frame. You're going to check in and see how the child is eating. How many glasses of milk a day are they consuming? The American Academy of Pediatrics recommends no more than 24 ounces of milk a day, 24 ounces in 24 hours. The reason for that is if kids drink a lot of milk, they're going to be full and they're not going to eat a lot of other foods, especially iron-containing foods. And also, if you're drinking a lot of milk, then you're actually preventing your body from being able to absorb the iron as well as it could if you didn't have a lot of milk in your intestines. Some parents will look very guilty and say, oh, my kid doesn't like milk. And I reassure them that that's absolutely fine. I think it's a little bit odd that we drink cow's milk anyway. So then I ask them, is their child consuming any other sources of calcium? So it's a great time to counsel and educate them on the importance of calcium intake and bone mineralization, especially while their children are growing. Remember to ask them what type of milk they're drinking too. Is it primarily chocolate milk? Is it whole milk? Is it non-fat milk? So encouraging them once again to make the healthiest choices possible. And then you're going to ask, do they eat any fruits or vegetables? If the child is old enough to speak back to me, I'm going to ask them what fruits and veggies they like. Can they name some for me? This is a great time to educate everybody on the importance of trying to eat 5 servings of fruits and vegetables a day. So I'll quickly go through how big a serving of a fruit or a vegetable is. I'll encourage the parents to let the children choose out the fruits and vegetables, maybe help them prepare them, help to grow them, all of those things so that the kids are more invested in eating fruits and vegetables. You're going to check in and see how many times a week does the child eat fast food. You can talk about healthier options at fast food restaurants if the family doesn't have a lot of other options. Checking in to see how much soda kids drink. I'm always a little bit surprised at how young kids start drinking soda. So oftentimes soda is put into a bottle and given to a child before they're even 1 year of age. Sports drinks, families spend so much money on sports drinks because they think that they're healthy. Things like vitamin water, Gatorade, those type of things. So it's a great time to educate them on how those are just sugar water and really a waste of money and less healthy for their child. How much juice does the kid drink? Once again, a lot of parents think that drinking juice is something that's really healthy for the kid and something that the child needs to do. So educating them that they really don't need any juice, and juice is also just sugar water. If they are drinking juice, maybe 1 to 2 cups a day maximum of 100% fruit juice.
You have unlimited juice? This party is going to be off the hook.
If a child is obese, and remember in pediatrics, we determine obesity not based on a set cutoff for the BMI, but we're actually looking at the percentiles on the growth charts for the BMI. So obesity is defined as a BMI greater than the 95th percentile. Being overweight is greater than the 85th percentile, and being underweight or failure to thrive is less than the 5th percentile. So if the child fits into that greater than the 85th percentile, which is overweight, or greater than the 95th percentile, which is obese, then this is a great time to gather a quick 1 to 3 day diet history. So what did you have for breakfast this morning? What did you have for lunch? What did you have for dinner last night? What did you eat between breakfast and lunch? What about lunch and dinner? What do you have after dinner? If you just ask for snacks, oftentimes they'll say, I haven't had any snacks. But if you are a little bit more thorough with your questioning, you're able to gather much more information. And then you have the opportunity to counsel them on what they're doing well. I love that you're eating breakfast every morning. Maybe instead of a toaster pastry, you could have a bowl of cereal, which would be just as simple and a lot healthier for you. I noticed that you're not eating a lot of fruits and vegetables. Can you think of some times in the day when you could grab a quick fruit or vegetable, or how you can add that in more? You're going to ask about activity levels. How much activity? And when I say activity, I mean the kid is running around and their heart is really pumping. How much do they get of that a day? The goal is to have about 60 minutes a day. Doesn't have to be all at once. Could be 10 minutes in the morning, 5 minutes in the afternoon, 10 minutes later on, as long as it's adding up to about 60 minutes a day. There have been a number of studies on this topic, and they have demonstrated that the more time a child spends outside, the more active time they have. So encouraging the parents to let their kids play outside. Now, in our patient population, and specifically within our community, a lot of parents don't feel safe letting their children go and play outside. And so I will absolutely respect their safety concerns and encourage them to have other ways that they could have their child play indoors. So invest in a jump rope, have some music videos or music that the kid can play and dance to. Somehow incorporate indoor activities so the child can still be just as active even if they're playing indoors. How many hours a day of screen time does a kid get? Screen time is specifically anytime you're sitting staring at a TV, staring at a computer, playing a video game, texting on a phone, or staring at a tablet. We want no more than 2 hours of total screen time a day. That's another fantastic way to educate the parents on encouraging the kids to get up out of their seats and move around. Further safety screening questions include, does a child always wear a seatbelt or ride in a car seat? Prior to your pediatric rotation, you should review the car seat regulations. The American Academy of Pediatrics recommends that all kids younger than the age of 2 years and 20 pounds sit backwards, facing backwards in their car seat, so a rear-facing car seat in the back seat. After 2 years, the kid can move to a forward-facing car seat, such as the one that's pictured in this picture on this slide. Starting around age 4 years and 40 pounds, they can sit in a booster seat. And then after age 8 years and 80 pounds, they can sit in a regular seat, but they should still be sitting in the back seat, always with a seatbelt, until they're 11. Does a kid own and use a bike helmet? So clearly this is a question that you would omit for a 6-month-old or somebody who's too young to actually ride a bike or developmentally unable to ride a bike. Does a child know how to swim? This is a great opportunity to do some education around pool safety or just open water safety. Is there a smoke detector at home? And is there a carbon monoxide detector at home? I have been pretty surprised over the last couple of years the amount of families that need education on the law of having a carbon monoxide detector at home. So that means that if the families are renting, their landlord needs to provide, it's a law in California, their landlord needs to provide a carbon monoxide detector as well as a smoke detector. There are a lot of detectors that have combined smoke and carbon monoxide in them, so that's nice and easy. And then reminding the families that they need to change the batteries for those twice a year. 1st of January, 1st of June are nice, easy times to remember to check and change those batteries. Is there a gun at home? I have had a little bit of pushback from some fellow colleagues who say, I never ask about guns because that just feels so judgmental. And asking about guns has nothing to do with the judgment of gun ownership and everything to do with the safety of the child in the house. So making sure that if there is a gun at home, that the family is well educated on the importance that the gun be stored in a locked cabinet and be stored separate from the ammunition. Educating the families on the number of accidental deaths that have occurred from kids finding and playing with the family gun. Does anyone smoke around the child? So talking about the deleterious effects of secondhand smoke, the importance of parents role modeling for their children, especially the preteens and teenagers, the importance of smoking cessation, giving them education about how they could quit smoking, even prescribing some medication for them to help them to quit smoking. I will counsel families that if they have a really hard time quitting smoking, it's not the right time for them, they're unable to quit smoking, that they at least go old school with their smoking. So always go outside, have a smoking jacket, smoking robe would be ideal. So something that they put on as they go outside to smoke, maybe even some gloves. They'll smoke their cigarette and then come inside, take off the robe, take off the gloves, wash their hands. And so that way they're limiting the amount of secondhand smoke that their children are being exposed to. Dental care. Does a child brush their teeth? How often do they brush their teeth? If the kid is less than 4 years of age, I encourage the parents to help the child brush their teeth. Focusing on the more superficial aspects of not brushing your teeth can be more helpful for the teenagers and the pre-teenagers. So you have really bad breath, your teeth look really dirty, nobody's going to want to kiss you. So important to brush your teeth at least twice a day. And then focusing on the cavities and the heart disease, general oral health for the parents. Has a child been to a dentist? Kids should be going to the dentist twice a year, every 6 months. How long, when was their last dental appointment? Did they have any cavities? When's the first time a kid goes to a dentist? There are some people who say first tooth, first dental visit. Kids start developing teeth around 4 months of age, up to 9 months of age. They can get their very first tooth. So you could take them to the dentist at that time. It's really just to start getting them used to the idea of somebody looking in their mouth. Usually around age 2 years of 3 years when they're able to cooperate, hold their mouths open, have their first dental cleaning and fluoride placement. Developmental screen. This is a huge component of the Well Child Check. There are a number of different tools to help us with this. Usually a simple set of screening questions will help determine if the child's at risk for developmental delay. We're typically looking at the developmental categories of gross motor, fine motor, speech and language, and emotional social development. So we'll look for delay in each of those categories. So those screening questions are going to be involved in each of those. I have a developmental checklist that I created not only for this lab, but also for students when they're out on their rotations. So you can certainly look that over and use that while you're out on your rotations. For teenagers, we have a special part of the history where we ask the parents to leave the room. It's called the HEADS exam. The HEADS exam is a confidential exam. It's absolutely fantastic. It's part of my favorite part of those teenage visits. It gives me the opportunity to role model for the parents talking to their teenagers as the young adults that they're becoming. It gives me the opportunity to do some counseling on teenagers or with teenagers on those important topics. Oftentimes I'm one of the few adults that will talk to them about these topics. And gives the teenager an opportunity to express any concerns or ask any questions that they have about some of these sensitive topics. For the HEADS exam, you always ask the parents to leave the room. So I say, now that Samantha is a teenager, I have some special questions I have to ask her alone. I'm going to ask you to please leave the room. I'll come and grab you as soon as we are done. I haven't ever had a parent have a concern or complaint about being asked to leave the room. As the parent is leaving the room, I will start to say everything that you say here is completely confidential. I don't put it in your chart. Even if your parent were to ask me what we talked about, I wouldn't share that with them. There are a few exceptions, and those exceptions include if you are at risk of hurting yourself or hurting other people, or if somebody else is hurting you. Those are things I'm mandated to report, and I'll have to talk about those. But otherwise, everything that is said within this portion of the history is just to help me help you with your health. HEADS is an acronym. The H stands for home. So the acronym of HEADS goes the order that we're asking these questions. They're going from kind of the most general to the more sensitive topics. So you're building rapport as you work your way through the HEADS exam. So home, asking the kid who lives at home. Do you get along with everybody at home? Do you feel safe at home? Education, what grade are you? In school, what do you want to do when you're done with school? Do you feel safe at school? Do you have enough friends at school? What are your grades like? Do you need any extra help? A is activities. What do you do when you're not in school? Do they have an after-school job? Do they have sports? This is a great time to talk about sports safety and sports injuries. If they're online a lot, this is a great time to talk about internet sites and internet safety. The first D stands for drugs, alcohol, and cigarettes. So do you or any of your friends ever drink any alcohol? If so, how much and how often? Do you ever do any drugs? And you want to list specific examples. So do you ever smoke pot? Have you ever tried meth? Have you ever tried cocaine? All of those type of things. And I always say you or any of your friends, because sometimes they'll feel safe admitting that some of their friends may do some of those things, but not safe admitting that they themselves do those things. Although I find with teenagers, if you're approaching them openly and honestly, they are going to be just as open and honest back to you. Do you smoke cigarettes? How much and how often? And then the big point for me around this drug and alcohol screen is educating them on the importance of never getting behind the wheel if they're drunk or high, never getting in the car with a friend who is drunk or high. So do you have somebody that is safe that you can call that will come and pick you up if you're ever in the situation where you or any of your friends have been using any drugs or have been drinking alcohol? The next D stands for depression. I ask, what do you do when you're depressed, as opposed to, do you ever feel depressed? So I usually provide a normalizing statement like everybody feels depressed at some point. What do you do when you're depressed? Do you have someone that you can talk to? This is a great time to offer a counselor, offer social worker, and leads nicely into suicide. Have you ever tried to commit suicide? Have you ever purposefully hurt yourself? Do you feel like hurting yourself or killing yourself now? And then finally, do you have a boyfriend or girlfriend or both? And every single time I always use that same statement. Do you have a boyfriend or girlfriend or both? Have you ever had a boyfriend or a girlfriend? Are you currently sexually active? Have you ever had sex? Talking about different types of sexual activity. And then the big point is using protection. So I will let them know this is something I say to all of my teenage patients, regardless of whether or not they're actively having sex. It is so important to always use barrier protection. So just using birth control pills or being on some sort of birth control is not enough. You need barrier protection because there are sexually transmitted infections that you could get. Some you get, you come here, you pee in a cup for me, we find out what it is, I give you medication, it's done, we don't have to worry about it again. Others, and it only takes having sex once in order to get them, you have sex, you contract the sexually transmitted infection, and you have them for the rest of your life. Things like HIV, which leads to AIDS, or herpes. So it is always important to always use a condom in some type of barrier method. And then we'll talk about different places where they could get condoms, places like Planned Parenthood. We have a little basket of condoms in our clinic, so talking to them about where those places are, and just general sex safety. So do I ask the parent or the child? Clearly for the heads exam, the parent is out of the room, so you are asking the teenager for that. For the rest of the questions, you're asking both, depending on the age and the developmental abilities of the child. As much as the child can answer, involve them in it. I try to talk to the child as much as I can because I'm about to do a physical exam on them. So I'm trying to build up rapport with them as well. It's also a great way to role model for the parents that their child can be spoken to in a mature way and their child can be trusted to give answers. And then, as I said, the heads questions are done with the adolescent alone and the parent not in the room. What do you focus on? Do I have to ask all of those questions? No, you can choose to focus on different aspects during each well-child check. However, as a student, especially as a third-year student, you probably want to be as general as you can be. So ask as many of those questions as you can, and then allow your preceptor to focus you as you further develop a relationship with them. And then clearly you're not going to ask questions like riding bikes or swimming about infants. So make sure that the questions are tailored to the age and developmental level of the child. And then once again, notice that throughout your interview, as you're asking questions, do you have smoke detectors? It's so important to have smoke detectors. So the entire time that you're asking questions, you're also counseling. You're providing that preventative care and anticipatory guidance. Vital signs, so temperature, heart rate, respiratory rate, and then blood pressure. You can get a blood pressure in a teeny tiny premature infant. But we don't routinely start screening for blood pressure, for elevated blood pressure, until the kid is 3 years of age. Once they're age 3 years, then we start routinely doing their blood pressure checks at each well-child exam. Remember that pediatric vital signs are normal. The ranges of normal are different than for adults. So this is a great chart to have. This is something that's nice to have as reference for your third-year rotations. So if you can get an app on your phone or something that has those pediatric vital sign normal ranges. So when you hear that really fast heart rate in an infant, oh, that sounds like the heart rate is about 140, you can look back at this and say, oh, actually that's pretty normal. Measurements. So until the kid is able to stand up steadily on their own, so typically until 2 years of age, kids usually start walking around 1 year of age, but you may not be able to get them to stand with both feet flat on the ground together, so you can measure their height. So prior to that, you're measuring their length, so you're actually having them lay down and measuring them from the top of their head down to the bottom of their feet. You need to make sure that they're staying nice and still as you do that measurement. After that, you're doing their standing height, always with their shoes off. Head circumference, we are routinely checking infants and toddlers' head circumference up until 2 years of age, making sure they're not growing too quickly or too slowly. I have now diagnosed 2 brain tumors in my practice based just on head circumference alone. So head circumference just continued to increase more rapidly than we expected it to. As I looked at the growth curves, I could see that head circumference had started at the 50th percentile and then went up above the 95th percentile. So the kids got MRIs, and unfortunately they both have brain tumors. So that's one of the reasons that we're always screening head circumference until 2 years of age. Weight for infants and toddlers, you have them lying or sitting down on the infant scale. It's really important for infants that you're weighing them naked every time. Number one, they don't weigh very much. And number two, those diapers, depending on how dirty the diaper is, how full of urine the diaper is, it can really alter the measurement of the child. So it can seem like the child has put on a lot of extra weight if they have that big, heavy diaper on. And then BMI. For kids older than 2 years of age, we start calculating their BMI, and we use those specific BMI cutoffs. Greater than 95% is obesity. Greater than the 85th percentile is overweight, and then less than the 5th percentile is underweight or failure to thrive. Growth charts. They're an integral part of every child's medical record. You are updating them every single time they come in. We're specifically looking at trends on the growth curve, right? So if I'm seeing a child for the very first time, let's say they're 3 years old, they're coming in to see me for the very first time, and their weight plots at the 5th percentile. Since this is their first time seeing me, it's the first plot on their growth curve in my office. I don't know a lot of information from that. If I get their prior medical records and I see that at their last visit or the year prior, their weight had plotted at the 50th percentile and now they're at the 5th percentile, I'm going to be much more concerned, right? I'm going to probably initiate a failure to thrive workup on that child. Versus if their prior plot point had been at the 5th percentile, now they're just following along that 5th percentile. It means they're a little bit small for their age, but it's nothing that I'm going to be too concerned about. So it's really important that we're looking at the trends on the growth curve. Remember, we're measuring head circumference until 2 years of age. We're doing BMI after 2 years of age. If you get an abnormal vital sign or an abnormal plot point, so let's say every single time the kid's height had been at the 75th percentile and now suddenly their height is at the 50th percentile, so it looks like maybe they're getting shorter, clearly you need to remeasure it. If you get an abnormal vital sign, and this goes with adults too, you get a really high blood pressure reading from the nurse who did the triage and checked the patient in, check it again yourself. Oh, anything that looks abnormal, always double check it yourself. The growth curves are available in basically 4 different sets. 0 to 36 months for males, 0 to 36 months females, and then 2 to 20 years for males and females. Using an electronic health record, it will automatically plot the child at exactly the right point on the growth curve for you. If you're in an office or a clinic that is still using paper charts, or if your EHR is down, then it's important that you know how to plot on a growth curve appropriately. So you can imagine plotting a child at a certain weight when they're 3 years is going to be pretty different than if they're 3 years and 11 months, right? That's going to push them much further over on that growth curve. So it's important that you're actually plotting them based on as closely as you can get to their exact age. Here's an example of trends on a growth curve. We can look at the pink dots, Mohammed. Mohammed has been at the 25th percentile for his height pretty much his entire life, so nice and normal. Looking at Jack, looks like Jack was just below the 25th percentile of height, and then starting around age 10, he started to increase his height pretty dramatically. So it looks like he had a growth spurt. I can also see that Jack has a lot more height points in there, so it actually makes me wonder if maybe Jack has been treated, maybe he's getting growth hormone or something. For some reason, he has more visits and seems to be increasing his height much more rapidly. Here's another example. This one is of an infant. You can see at the very beginning, the infant was kind of right at that 5th percentile, that lowest line on the growth curve. And for their weight, which is down at the bottom, which unfortunately you can't really read on here, their length and their head circumference, they have all been moving further and further away from that bottom line. So that's a very concerning sign. This child clearly has failure to thrive and needs to be worked up for it. Kids are getting hearing screens and vision screens every year, starting from the age that they can cooperate. So typically that's around 4 years of age when they can truly cooperate with a hearing or a vision screen. What do you examine? You're doing a full head-to-toe physical exam, ideally with the child in a gown or undressed so that you can look at all of their skin. Remember to respect the kid's modesty, right? You're going to use drapes and curtains, especially as a child starts to get older. You want to make sure that this isn't a traumatic experience for them. You are going to check their breasts and their genitalia for Tanner staging. I tell all of my medical students that once a child is outside of diapers, they shouldn't look at the genital area. Save that part for me. But depending on what your preceptor is comfortable with, usually I would avoid doing breast and genitalia exams unless your preceptor tells you to. This video from Columbia is a great video just on how to do your first pediatric exam. So what's the assessment? So I write up everything, right, in the subjective portion. So in the subjective portion, you're including everything, including if they have guns, if they have smoke detectors and carbon monoxide detectors, if they're in car seats, what their typical diet is like. All of that stuff is usually going under the social history section. And then you document your good physical exam, including the percentiles that their height and weight falls into. And now for the assessment. What do I write for the assessment? For a well child exam, the assessment is WCC, well child check. That's it. That's your assessment. You do not need a differential diagnosis. Now, clearly, if anything else has come up during your history and physical, like they didn't pass their hearing screen, their blood pressure was elevated, their BMI is greater than the 95th percentile, those are all going to be separate assessments for you. What's the plan? The plan is all of that anticipatory guidance that you provided as you were going through your history. So anticipatory guidance provided on nutrition, exercise, school performance, dental care, home safety, pool safety, all of those things. You're going to give immunizations as they need them. We do hemoglobin and lead screening at age 1 year and 2 years. So hemoglobin screening for anemia, the most common anemia that we pick up is iron deficiency anemia, right? So if the kid has been drinking too much milk, not eating enough iron-rich foods, they're going to become anemic. And then we're screening for lead toxicity at 1 year and 2 years in all children, regardless of whether they're symptomatic or not. In teenagers, we do STI screenings. If the child does fall into that BMI of greater than the 95th percentile, you may do some screening labs, fasting cholesterol, glucose, hemoglobin A1C, and then AST and ALT, those liver transaminases, looking for fatty liver disease, non-alcoholic steatohepatitis, and then any plan pertaining to the other diagnoses. So if they failed their hearing screen, you're probably going to refer them to an audiologist.
So what will you be doing for this lab again? You're going to be examining a pediatric patient. The patient's coming to see you for a well child exam. You're going to plot patients on growth charts and document their percentiles. You're going to ask the child and the parent, who may be the kid's actual parent, or it might be a faculty member who's acting like the child's parent, all of the pertinent well child check history taking questions. You're going to perform a physical examination respecting the child's modesty. You're going to write age, weight, and diagnosis appropriate amoxicillin prescriptions. And then you're going to present your patient to the class as though you were presenting it to your preceptor. So after all of this, you should have some extra tools, you should have some extra resources, and some extra confidence. So when you go and do a well child exam, or really any screening examination, you'll feel more comfortable with what you're doing.
And then here are some references for more information. If you guys have any questions about anything, please feel free to contact me. I'm excited about this lab. I think you guys will have a lot of fun with it. That's all. Thanks so much for listening.